Um, okay, perfect. Now start recording. Okay. Okay, when they have a low IQ, when we mean that, we say they're usually less educated. Um, they might like it might come up in the vignette that they left school early or something. If it's gradual onset, so these symptoms came over a long period of time rather than it coming abruptly and without warning. Um, a premorbid history of social withdrawal. If there's no obvious precipitant, so where they didn't have like an event that occurred in their life or where they didn't, you can't find a cause like drugs or something, then it's um, more likely for them to have a poor prognostic indicator. And also those negative symptoms that we talked about. Okay, so this is we're gonna go through the typical versus atypical antipsychotics. This can come up in OSCE. It can be like a um we need to advise on medications. I need to advise someone on how to on what an antipsychotic is, how to take it, and the side effects and the monitoring about it. So we can go through that now. So the typical or first generation antipsychotics, some people sometimes call them, those include like haloperidol and things like that. So they're not really used now because they had what we call extrapyramidal side effects. So it can actually trigger Parkinson's. So you would get drug-induced Parkinsonism. So that's bilateral tremor compared to the unilateral tremor in idiopathic Parkinson's. You can get acute dystonia, which is involuntary and sustained muscle contractions, tardive dyskinesia, and akathisia. So we need to know about this. To treat it, you can use the prostaglandin that we talked about, the anticholinergic medication. Um, and you can also get this anti-muscarinic side effects. So can't see, can't pee, can't spit, can't shit. So blurred vision, urinary retention, dry mouth, and constipation. But nowadays we usually stick to the newer, like second generation or atypical antipsychotics. So because these have fewer extrapyramidal side effects, but they do have a lot of side effects that you still need to counsel the patient on. So this will come up like if you need to explain in the OSCE. So things you need to explain is hyperprolactinemia, so hyperlactin. So if you want to look at for galactorrhea, impaired glucose tolerance, amenorrhea when they don't have a period, infertility, and especially in men, you can get gynecomastia as well. Um, also get hypercholesteremia, dysglycemia, and diabetes. So schizophrenia, people with schizophrenia taking antipsychotics have an increased risk of a cardiovascular disease. So that needs to be monitored. So again, sedation, weight gain, and neuroleptic malignant syndrome. So we'll go through that again, but Hassan talked a little bit about it, but we've got a slide about it coming up in a bit. And in the elderly, there's an increased risk of stroke and increased VTE risk. So you can see there's a lot of quite serious side effects with these medications. Um, so it's important to counter the patient on this. Okay, so these are some examples of some common atypical antipsychotics. So you got olanzapine, risperidone, quetiapine, amsuloprid. So with these, I'll usually suggest that where the notes kind of highlight for each drug, I'll say you just remember those for all the drugs. So you need an ECG beforehand. Carbamazepine and cytotoxic drugs are contraindications, and common side effects are that metabolic syndrome, sore throat, fever, hypersalivation, constipation, drowsiness, tachycardia. Sounds like the anticholinergic, the antimuscarinic side effects. And you also got a third generation, aripiprazole, which has fewer side effects and doesn't cause hyperprolactinemia, but people it's usually like a third line because they don't usually work as well as the others. So if the person's it's only really used if a person is experiencing quite severe side effects and they really can't tolerate like olanzapine and risperidone and things like that and quetiapine. Okay, so clozapine counseling. So this again a atypical antipsychotic. Now the reason why you would only give this after you have tried at least two other drugs for at least 6 weeks. And the reason is because there's a major risk of agranulocytosis. So You get neutropenia, there's an increased risk of infection, increased risk of sepsis. So you got to monitor this really, really tightly, taking FBCs. Um, but again, this other side effects are something like the hypersalivation, a risk of also myocarditis. So sometimes they do. That's why you do ECGs, and that's why you also do. Sometimes they do echoes as well. You get constipation, which is the most common side effect. Um, so yeah, these are the monitoring that you need to advise the patient on, and that they usually ask you to explain in if the, like an OSCE station to explain this medication does come up. So you want to do your ECG because it can also cause QT elongation. Measure your lipids, measure the weight at 3 months and then yearly. Measure the fasting blood glucose at 6 months and then yearly. And then, like I said, the FBCs at weekly for 18 weeks. So this will usually happen when a patient is like in an inpatient unit. So they've given clozapine for the first time and they're kept there so they can measure them every week for 18 weeks. And then it'll be twice weekly for a year. And then it'll be every month after that. And a lot of these patients are at risk of smoking as well. So then, which can affect clozapine. So then a dose adjustment might be necessary as well. Okay, so neuroleptic malignant syndrome. So Hassan talked a little bit about it. So it's a reaction to antipsychotics, which usually occurs about 4 to 11 days after. So the risk factors are high potency drugs like these. I mean, these antipsychotics are quite potent anyway. If they've changed their dose recently, they're dehydrated, or they're taking lithium as well, or any abrupt withdrawal of these anticholinergics like that procyclidine. And how the patients present is that they're really rigid, and so that can even affect their, like, the muscles are rigid, but also their respiratory muscles. So it can have respiratory depression. They come with an extremely high fever and extreme confusion, and the vitals are fluctuating rapidly. And the key thing they might ask in like an SBA will be what will be an important blood test to do. So that'd be your creatinine kinase because that will appear raised. So the management is kind of supportive. So cool them down because they're really hot, stop the antipsychotics, obviously, and monitor the vital signs and admit to the usually ITU. There are some medications that you can use, such as dantrolene and bromocriptine. And then after that, you'll then replace the current antipsychotic with small doses of a different antipsychotic with a short half-life and a low dopamine affinity. I think that's usually aripiprazole for that. Okay, so anorexia. Um, so the diagnosis is usually. Oh yeah, if you guys have any questions, like stop me if I'm going too quickly. Sorry. Okay, so diagnosis is via the DSM-5 criteria. So the way we classify anorexia is where you restrict, so you're limiting the amount that you eat, and it's usually due to an intense fear of gaining weight, even though the patient is underweight. Um, and they can't, like, similar to schizophrenia, they lack the insight into the condition. They don't see the seriousness of having a low body weight and that and the effect that it can have on their health. Um, so they used to calculate BMI and also have amenorrhea as part of diagnosing it, but that's no longer part of it. So you can still diagnose a serious eating disorder even without that. So the management is CBT again, most of these. You follow this mantra. I won't go too much into it. You can have a look if you want to research it. I don't think you need to know too much about it. But if it is quite serious and to the point where the patient will not accept advice that you're kind of giving, there are psychiatric wards dedicated to anorexia that people can be admitted to and treated for. Um, and they can even be admitted to general medical wards as well. Um, but these are sort of the high risk parameters where basically if you fall under any of these, then the patient will need to be admitted. So BMI less than 13, weight loss is more than 1 kg per week, heart rate's under 40, BP's under 8 or 50. I won't read all of them, but basically you can see that their vitals are abnormal. And but the important one to consider is if they cannot sit up, like stand up from sitting without using their hands, that's kind of a severe sign of anorexia and that they need to be admitted. And it can also cause bradycardia on an ECG with a long QT and T wave changes as well. This is what we can come up a lot as well. I've seen a lot in SPAs is refeeding syndrome because this is a medical emergency. So what you really don't want to do with these patients if they come to A&E is start giving them food, lots of food straight away because this can happen. And what will happen is they will have this low phosphate, low potassium, low magnesium, and they'll get this high glucose and high CK. And this is really dangerous because obviously the electrolyte imbalances can cause rhabdomyolysis, cardiac and respiratory failure, seizures, arrhythmias, and sudden death. So this is something that is really kept an eye on. I won't really go into the pathophysiology too much, but you can see on that picture onto right there. So you can take a screenshot about it. So what they usually do is you want to start feeding them slowly over 4 to 7 days with a gradual increase in calorie intake. You want to get a dietitian involved and you want to start prescribing them these nutrients that they miss out. So that thiamine, the vitamin B complex, and just multivitamins in general. So this is something that can come up in SBAs. Like I said, bulimia. So bulimia can be, I find it confusing initially with anorexia, but the way to differentiate it is that you have recurrent episodes of binge eating, whereas with anorexia, they're usually just not eating. But again, it's that same thing about having that control of body weight, which is really key for the person. And then they will eat lots, but then have to feel guilty about that eating a lot of food, and will have to overcome that by starving themselves, by vomiting, like making themselves vomit, having laxatives, or over exercising. And people can say over exercising, that's meant to be good for you, but if it's over exercising with the intention of losing weight, that still counts as binging. It's like over exercising with the intention of losing weight to an unhealthy obsession and having that preoccupation with controlled body weight, that can be considered as binging, as a practice to overcome binging. Sorry. So what's the management? So if it's mild, again CBT, and like a food diary. So and you can prescribe fluoxetine to help with binging and purging, but you also, like with anorexia, need to consider admission to like a specialist eating disorder unit. Yeah. Okay, so this can come up again in O&G a lot. So postpartum mental health. So so use the Edinburgh Personality Scale, and generally when you have baby checks, they always do screen for postpartum mental health. And it's important to also screen for mental health conditions during pregnancy. So there's three kind of categories that we try to look at. So either have baby blues, which is super common. It's typically seen 3 to 7 days after birth, and it's usually common like after the first pregnancy. And you see the mothers as anxious, tearful, and irritable. But if there's no signs of severe signs that like signs of postnatal depression or psychosis, which we'll go into, then it's just reassurance and support, offering CBT and having a health visitor. You don't want to start medications. You don't want to consider hospital admission because it's so common and they're not at risk. They just need support. With postnatal depression, this can affect around 10% of women. So the timeline's going to help you differentiate between the three. So baby blues is 3 to 7 days. Postnatal depression is about a month after, with a peak at 3 months. And there's kind of the similar features that are seen in depression that we talked about. So lack of motivation, problems sleeping, minor problems eating as well, um, concentrating, motivation, things like that. But what's really important again is still reassurance and support. CBT again can be beneficial. It says certain, you can use sertraline and paroxetine. I think there's the only two that are safe in pregnancy, but I don't think that's really commonly used. Um, that's if symptoms are severe. Um, but again, you don't really want to start medications. It's more about the reassurance, support, and CBT initially, and then you get the psychosis. This is rare. This is 0.2% of women, and this is usually within the first 2 to 3 weeks of birth. And you get that similar to bipolar. So you get this mood swings, so depression, you get the mania, and you might get hallucinations as well. And here, the admission to hospital is usually required. And this is, you don't separate the mother and the baby. You into like a mother and baby unit. And there is a risk of recurrence as well in future pregnancies. So that's why we say it's important to discuss with women who maybe are of childbearing potential and do have a new or existing mental health problem, um, to discuss with them like contraception, any plans for pregnancy, or if they were to have a pregnancy, how might affect their mental health, including how it might, if it would cause them to relapse, um, how it would affect them, the baby, and how a mental health problem might affect parenting as well. Okay, so self-harm. Um, so the risk assessment is very important. So our station last year for OSCE was on a person who had taken a paracetamol overdose, and we had to take a history. So Hassan already went into like the kind of general history, but this is a really important part that you want to consider, like a risk assessment. I mentioned it before. So do you have thoughts of harming yourself? Do you have thoughts of harming others? And do you think that they're at harm from others? Is like the three things that you want to ask. And if they do have thoughts of self-harm or suicide, you want to ask, go into depth about it. Do you have any previous suicide attempts? If they were to commit suicide, how would they plan on doing this? Have they already acted on planning on doing this? Writing letters, um, writing up wills, getting their finances in order, stockpiling medication to prepare for an overdose, for example, um, or like, thoughts about trying to hide themselves afterwards, and also ask them about anything that will stop them from acting on these thoughts. So protective factors, family support, religion, children, work. Um, I would write this down because we had a station like this last year. I don't know if it could come up again. I mean, it could come up again, but this was important to ask in that station. So yeah, so this is again the what our station was about that we had last year. So like I said, he had a um so our station was that a man had a paracetamol overdose. So he wanted to go into kind of a falls history, so a seizure history, before, during, after. What were they doing before? How were they feeling before? How long did they plan this for? Was it impulsive? Was it long term? So like I said, did they want to be found afterwards? Like, did they lock a door? Did they do an isolated location? And what exactly happened? If they took a paracetamol overdose, for example, like he did, what did they take? Paracetamol. How many did he take? Did they take? And over how long did they take it for? Um, any use of any other drugs or alcohol during the time? And what was their intention? Were they intentionally trying to commit suicide, or were they trying? Some people have actually said, I thought it would put me to sleep for a bit. I thought it would make me feel better. Some people, you think, would come in with intention, having taken an overdose with the intention of committing suicide, but actually is for other reasons. So finding out what the intention was is really important. And then how do they feel now? Do they feel angry, regretful, relieved about it? Do they still have plans to end their own life? And again, the protective factors. So the reason you're doing this is because you're trying to consider the risk of them. If you were to send them home from A&E today, would they go home and try commit suicide again? Or do they need to be admitted to the ward or admitted to an inpatient unit? Um, so that's what you're trying to figure out from taking this history. So if you are so things that would make you worried about them being at high risk and that you think they need to be admitted to an inpatient unit, like you could be the F1 seeing this in A&E, you don't need to be doing that. This could actually happen. So a history of self-harm or previous suicide attempts, other mental health disorders, drug and alcohol abuse, a planned attempt, poor social support, so like lack of the protective factors we're talking about, and if it was a violent method. Okay, so this kind of a summary. You guys can take a screenshot of this. Um, with all the conditions, the duration of symptoms, and what we'll say is a first line management. This is quite helpful just to keep it all on one page. Give you a minute, take a screenshot. Cool, and that's the end of the talk. If you guys can fill in the feedback form, I really appreciate it. And if you have any questions, please let me know and I can try to answer it, or I might have to call help from Hassan. But yeah. Cheers, guys.